ஹலோ சார், பார்மகோதெரபில இருந்தா சார்?
இந்த இது எண்டோஸ்கோபிக் தெரப்பில இந்த மேல ஹைப்பர்டென்சிவ் கேஸ்ட்ரோபதி. அடுத்த நெக்ஸ்ட் பேஜ் 1447. அதுல மேல ரைட் ஹேண்ட் சைடுல ஃபர்ஸ்ட் பேராகிராஃப் இன்டர்வென்ஷன் தெரப்பிக்கு முன்னாடி.
So in the variceal bleeding, in first year of the variceal bleeding, there is an increased risk. The rebleeding rates decreases by 15% annually thereafter. Although a single episode of recurrent hemorrhage does not signify the failure therapy, there should be a significant hemorrhage and multiple episodes and portal hypertensive gastropathy should be there to conclude that there is a failure of endoscopic therapy. Then a course of chronic endoscopic therapy should not be undertaken for a non-compliant patient and those living in a long distance from advanced medical care because they can't come in emergency. Here they have given picture. There is a O-ring. The O-ring is used to for band ligation. In intervention therapy, the major limitation in tips is shunt stenosis and shunt thrombosis. Then total shunt occlusion occurs in 10 to 15% of patients. Then shunt stenosis and shunt thrombosis often followed by recurrent portal hypertensive bleeding. Tip stenosis and occlusion have become less frequent with use of PTFE. Then, but another one disadvantage is development of encephalopathy in TIPS patient. Then when actually TIPS is used when only short-term portal decompression is required, like in liver transplantation candidates who fail to respond endoscopic therapy and pharmacotherapy, and therefore they are well suited for TIPS followed by transplantation when a donor organ becomes available. So to buy some time, TIPS can be used. But in case of usually after 1 month, there will be high chance of development of encephalopathy. The next page. And in this below diagram 54.21, they have told the procedure of TIPS. Like a 5F catheter is placed in the right hepatic vein, entering in the right internal jugular vein, then IVC, then right atrium, then come to the right hepatic vein. Then wedged hepatic venography is performed with CO2 gas to opacify the portal venous system. Then using the wedged hepatic venogram images as a guide, needle is advanced to the wall of the right hepatic vein and directed in an anterior-inferior direction to assess the right portal vein. Once the portal vein is cannulated, then CO2 is injected in the parenchymal tract to exclude the transgression of bile duct and hepatic artery. Once the proper placement is confirmed, then TIPS endoprocess is deployed, then which creates the shunt between the portal vein and hepatic vein. Then next page. Here they have told the surgical therapy. And another one point in TIPS is the patient who are unlikely to survive long enough for the TIPS to malfunction. For those patients also TIPS can be used. Then surgical therapy. In surgical therapy, these procedures are effective because they all decompress the portal venous system to varying degrees by shunting portal flow into the low pressure systemic venous system. Here also there is a complication, portal systemic encephalopathy and accelerated hepatic failure is there. In addition to venous variceal compression, selective, partial and portal systemic shunts also aim to preserve hepatic portal perfusion and therefore to prevent or minimize the adverse consequences of these procedures. Then first come to the non-selective shunts. Non-selective shunts they have given in above 54.22. Here they have given end-to-end portocaval shunt, also called as ECK fistula. In this, there is a high chance of hepatic encephalopathy chances there. The next diagram, side-to-side portocaval, there is a increased risk of hepatic encephalopathy, but slightly decreased risk. Then come to the third point, interposition shunts. Here, using a graft or a PTFE to join portocaval or mesocaval or mesorenal. Mostly in non-selective shunt, when we use more than 16 millimeter, when we use more than 60 millimeter stents are called as stents are used in non-selective shunts. When it is less than 10 millimeter, then it is called partial. Then come to the last one, conventional splenorenal shunt, also called as proximal splenorenal shunt or Linton shunt. These are used in, these are used as non-selective shunts. Then come to the last para here. Therefore, these procedures decompresses splanchnic venous circulation and intrahepatic sinusoidal network because the liver and intestine are both important contributors to ascites formation. In side-to-side photosystemic shunts are the most effective shunt formation, the shunt procedures for relieving ascites as well as preventing recurrent variceal bleeding. Okay, then side-to-side shunts also accelerate hepatic failure and lead to post-shunt encephalopathy. Next page. The conventional splenorenal shunt consists of anastomosis of proximal splenic vein to the renal vein. Splenectomy is also performed here in splenorenal shunt, Linton shunt, because the smaller proximal rather than the larger distal end of splenic vein is used here. So the shunt thrombosis is more common after this procedure than after the distal splenorenal shunt. Then the major advantage of this procedure is that hypersplenism is eliminated in splenectomy. Then come to the last line. In general, a non-selective shunt is constructed only when TIPS cannot be performed or when TIPS fails. Because TIPS and non-selective shunts are almost same because there is a same chance of developing liver and encephalopathy problems are same. Then come to the selective shunts. Selective shunts, the first one is Warren shunt or distal splenorenal shunt. Here we are not going to do splenectomy. Here in the distal part of the splenic vein is attached to the left renal vein. Also, we have to, which consists of interposition of vein graft between left gastric vein. Sorry. Actually, this distal splenorenal shunt consists of anastomosis of the distal end of the splenic vein to the left vein and interruption of all collaterals. So the coronary vein and gastroepiploid vein also ligated. This results in separation of portal venous circulation into decompressed gastrosplenic venous circuit and high pressure superior mesenteric venous system that continue to perfuse the liver, so that some amount of toxins and which is going to the liver also getting detoxified and there is a less risk of encephalopathy. Then the distal splenorenal shunt tends to aggravate rather than relieve ascites. So in non-selective shunt, there is a the ascites is decreasing, but in selective shunt there is a increase or it aggravate the ascites. Thus, patient with medically intractable ascites should not undergo this procedure. Another contraindication to distal splenorenal shunt is pre-splenectomy, because after splenectomy there will be a splenic vein thrombosis will be there. So when a splenic vein diameter is less than 7 millimeter, is a relative contraindication to the procedure because the incidence of shunt thrombosis is high when the small diameter of vein is used. Then last para, although the distal splenorenal shunt results in portal flow preservation in more than 85% of the patient during early postoperative interval, the high pressure mesenteric venous system is gradually collateralized and to the lower pressure shunt, resulting in loss of portal flow approximately 50% of patient in 1 year. So from a superior mesenteric vein, there is a collateral formation, the splenic or renal vein, that leads to shunt failure, or there is a that continue to the liver portal circulation is interrupted. The degree and duration of the next page, the degree and duration of the portal flow preservation depend upon the cause of the portal hypertension and technical details of the operation. The technical details mean the extent which mesenteric and gastrosplenic venous circulations are separated. Then modification of the distal splenorenal shunt, like purposefully or inadvertent omission of coronary vein ligation. Coronary vein is left gastric vein. Ligation results in early loss of portal flow. So even when all major collateral vessels are interrupted, but still the portal flow may be gradually diverted through a pancreatic collateral network. That is the connection between the pancreas and splenic vein. This pathway can be discouraged by dissecting the full length of the splenic vein from the pancreas. That is splenopancreatic disconnection, which results in better preservation of hepatic portal perfusion, especially in patients with alcoholic cirrhosis. However, this is challenging procedure. Then come to below. Considerably fewer data are available regarding selective shunting in non-alcoholic cirrhosis and non-cirrhotic portal hypertension, because hepatic portal perfusion after distal splenorenal shunt is better preserved in these disease categories because the liver is normal. So when the blood goes to the liver, there will be detoxification. There will be less toxicity to the brain. So one might expect improved results here. Then schistosomiasis also has demonstrated lower frequency of encephalopathy after distal splenorenal shunt than after a conventional splenorenal shunt. Then after that, here they have given some studies only. Then come to partial shunts. In partial shunts, the concept of partial shunts is the hepatic portal perfusion, the preservation of hepatic portal perfusion, then effective decompression of varices, and maintenance of some residual portal hypertension. Initial attempts at partial shunting consisted of small diameter vein-to-vein anastomosis. Here, more recently, a small diameter interposition portocaval shunt using PTFE graft combined with ligation of coronary vein and other collateral vessels were described. So, when the prosthetic size is less than 10 millimeter, then hepatic portal perfusion is preserved in most of the cases. But in when there will be a more blood diverted to the system, then there will be a failure of shunt also. Then hepatic transplantation. Liver transplantation is not a treatment for variceal bleeding. So when the patient is having variceal bleed only, then liver transplant is not the treatment of choice, but rather he needs transplantation when there is a end-stage hepatic failure. Also, transplantation is not indicated for some more common causes of variceal bleeding such as schistosomiasis and active alcoholism. Okay, I will tell next. Then come to the next page. There is accumulating evidence that variceal bleeders with well-compensated hepatic functional reserve like child tube class A and B plus are initially better served by non-transplantation strategies. Then turn the next page for a chart. Figure number 54.26. Here they have given the protocols. Like in non-alcoholic patient and abstinent alcoholic cirrhotics. Here, when the patient is continuously alcoholic, then he is not a candidate for transplantation. So when he stopped taking alcohol, then he is a candidate for transplantation. That's only they are telling. So here, when the patient is having child class A or B or child class C. In child class A or B, we have to try for conservative treatment. Take conservative treatment we will try, but when the disease is progressing, ultimately we will go for transplant. In child class C, the patient will directly go for transplantation. Then below diagram, here non-cirrhotic patient, then active alcoholic patient, elderly patient, and severe cardiopulmonary disease who is not eligible for renal transplantation. Then we will try for some other treatment. Like below, come to the last. If it is the controllable ascites, then compatible anatomy, there is no ascites, then we can go for selective shunt or tips. When the patient is having intractable ascites, then obviously we have to go for non-selective shunt. Then splanchnic venous thrombosis, then we can go for devascularization procedure. Then there is a Sugira and Hassab procedure. The two procedures are there. That is not given here. Two procedures are for devascularization procedure.
One more MCQ. Those who have ready access can go for endoscopic therapy. Only if they don't have access, we have to opt for shunt surgeries.
Okay, the access means the availability of endoscopy.
Availability of endoscopy.
Availability of endoscopy. Okay. Then that is what they have given in algorithm of management of variceal bleeding. Then one more point. Patient with medically intractable ascites in addition to variceal bleeding best treated with tips when less invasive measures fail to control the bleeding. If the tips eventually fails, an open site to shunt can be constructed if the patient has reasonable hepatic function and not a transplantation candidate. Okay, then come to infectious disease. First one is pyogenic abscess. Initially, pyogenic abscess was like because of acute appendicitis. The most common age group was 20s and 30s. Nowadays, it is 40s and 50s. Then male to female ratio is 1.5:1. Then comorbid condition also associated with this, that is cirrhosis, diabetes, chronic renal failure, and history of malignant disease. Then pathogenesis. In pathogenesis, here the liver is probably exposed to the portal venous bacterial loads. Usually that is cleared off liver, but when the development of hepatic abscess occurs, when there is an inoculum of bacteria regardless of the route of exposure, it exceeds the liver ability to clear it. When the liver can't clear it, then there is a hepatic abscess. The potential routes are, most common route is biliary route, then portal vein, then hepatic artery, then direct extension of nearby nidus infection, then trauma. First one is biliary. The most common is biliary. Here, like because of bile stasis, there is a bacterial colonization infection, then ascension into the liver. In Asia, intrahepatic stones and cholangitis, like recurrent pyogenic cholangitis, which we will discuss later, are common causes. Whereas in West, malignant obstruction is most common. In pre-biliary enteric anastomosis also been associated with hepatic abscess formation, likely because of unimpeded exposure of biliary tree to the enteric organisms. Then come to the portal vein. So when the infection is going through the portal vein, ascending portal vein infection is called as pylophlebitis. The most common cause of pylophlebitis are diverticulitis, appendicitis, pancreatitis, and inflammatory bowel disease, pelvic PID, perforated viscous, and ampulitis in newborn. So hepatic abscess has been associated with colorectal malignant disease. Then any systemic infection, like endocarditis, pneumonia, or osteomyelitis can result in bacteremia and infection of the liver through the hepatic artery. Also, immunocompromised patient also in AIDS, HIV, and other malignant disease, there is a higher risk of hepatic abscess. Then hepatic abscess can be the result of direct extension of the infection process. Here examples are suppurative cholecystitis, then subphrenic abscess, perinephric abscess, and even perforation of the bowel directly into the liver. Then penetrating and blunt trauma also can result in intrahepatic hematoma or area of necrotic liver, which subsequently develop into an abscess. Other mechanism of iatrogenic hepatic necrosis, such as hepatic artery embolization and thermal ablative procedures nowadays, because of recent advances, they are complicated by abscess. Usually, no cause of hepatic abscess is found. Cryptogenic abscess predominate in many series, are more common in some case reports. Cryptogenic means the unknown of origin. Then in patient with cryptogenic hepatic abscess who have undergone computed tomography with ultrasonography, it has been argued whether diligent search for cause should be ensued. Then pathology and microbiology. Most commonly, hepatic abscess are common in right hemiliver, accounting for 75% cases. Because actually it is not known, but the preferential laminar flow to the right side has been postulated. In Bailey, they have given, like, because from superior mesenteric vein, the infection directly go into portal vein, then portal vein directly go into right side of the portal vein, then directly go into the lobe 7. Because of that it is common in right side. In left side, it is 20%. Then cardiac lobe also rarely involved, that is 5%. So right lobe 75, left 20, then cardiac lobe 5%. Next page. Most commonly, these hepatic abscesses are solitary. In hepatic abscess can vary in size from less than 1 millimeter to 3 to 4 centimeter in diameter, which can be multiloculated or solitary also. And heterogeneity of the routes of infection makes the microbiology variable. Abscess from pylophlebitis or cholangitis tend to polymicrobial with high preponderance to gram-negative bacilli. Then hepatic abscess are polymicrobial in nature, account for approximately 40% of cases. Some have suggested that solitary abscess are more likely to be polymicrobial. Then examples like gram-negative most commonly are E. coli and Klebsiella pneumoniae. Then others are like Staphylococcus aureus, Enterococcus viridans, and bacteria and bacteroides. Then Klebsiella, here it forms the gas-forming abscesses. So, which is gas-forming abscess in hepatic, that organism caused by Klebsiella. Then Enterococci and viridian streptococci are generally found in polymicrobial abscesses. Then, whereas staphylococcal infections are usually come as single organism. Then other organisms also they have given here. Then clinical features. See table 54.4. Here they have depicted the most common symptom is fever and chills. The night sweats, malaise, then anorexia, weight loss, nausea and vomiting, abdomen pain, chest pain, and cough. Then next column, the duration of symptoms is variable, ranging from an acute presentation to chronic illness lasting for months. So with identified abdominal disease, whereas chronic presentation is often associated with cryptogenic abscess. A rare complication specific to Klebsiella hepatic abscess is endogenous endophthalmitis. So Klebsiella causes gas forming, also endogenous endophthalmitis or ophthalmomyelitis. Then more common in diabetes. On physical examination, the same because of inflammation, there will be a fever, tenderness, then jaundice. In chest radiograph, there will be it is found in 25% of patients. Then hepatomegaly will be there. Ascites, splenomegaly, and severe sepsis also can be there. Then in pyogenic abscess, the main thing is abnormality of LFT. This is the differentiating thing from amoebic abscess. So ALP levels are might be elevated in 80% of the patients. Then severe abnormalities of liver function are almost always associated with biliary disease. Hypoalbuminemia or mild elevations of PTINR can be present to reflect the disease chronicity. Then radiological investigation, most commonly used ultrasound, investigation of choice, CECT. Also in blind abdominal X-rays, it can be helpful. They can show the air fluid level and portal venous gas in case of Klebsiella infection. Then sensitivity of the ultrasound. Sensitivity of the ultrasound is in for hepatic abscesses 80 to 95%. Then CT demonstrate the similar findings of ultrasound and lesions are lower attenuation than surrounding. The lesions are lower attenuation than surrounding hepatic parenchyma in CT. Then high quality CT scans can demonstrate very small abscesses and can more easily identify multiple small abscesses. Also, the sensitivity of CT is 95 to 100, almost 100. Then differential diagnosis, most commonly is differential diagnosis.
Clinical features low on point, and the most common clinical feature is what?
Fever, sir. Fever and chills.
Okay. Least common is jaundice.
Okay. Least common is jaundice, 20%. Sir, but எல்லா இதுவும் முக்கியமா சார் இதுல நிறைய கொடுத்துருக்காங்க.
ஆமாமா, எப்படி வேணாலும் கேட்பாங்க. ஏன் நீட் பிஜிக்கும் இதுக்கும் அதான் டிஃபரன்ஸ். நீட் பிஜினா 21 சப்ஜெக்ட்ஸ், 19 சப்ஜெக்ட்ஸ், 20 சப்ஜெக்ட்ஸ் இருக்கும். இது ஒரே சப்ஜெக்ட் தான், அதனால they can ask whatever they want. So every line is important.
Okay. Then come to next table, 54.5. Some important factors are the amoebic abscess and pyogenic abscess. Age group is 20 to 40 years, and pyogenic abscess it is more than 50 years. Then most commonly the amoebic abscess are solitary in nature. Then pyogenic abscess in 50%. In amoebic abscess that is 80%. Then travel to endemic areas more common in amoebic than pyogenic. Then diabetes is more common. Diabetes, then jaundice elevated, then abdomen elevated LFT are more common in pyogenic. Then positive blood culture is more common in pyogenic. Then come to treatment. Actually, in treatment for broad spectrum IV antibiotics should be started immediately to control ongoing bacteremia and is associated with complication. Blood samples and specimens of the abscess from aspiration should be sent for aerobic and anaerobic cultures. Until cultures have been specifically identified for specific organism, then we have to continue broad spectrum antibiotics like ampicillin, aminoglycoside, metronidazole, and third generation cephalosporin metronidazole, or we can use. Next page. Antibiotics are at least required for 2 weeks. Then nowadays they can use pigtail incision also, percutaneous drainage also. Here relative contraindication for percutaneous drainage incision are ascites and coagulopathy and proximity to the vital structures. Then there is no one mark here.
What is the most common antibiotic used?
Most common metronidazole, sir.
Actually, pyogenic polymicrobial aminoglycoside and metronidazole, or a third generation cephalosporin with metronidazole.
Okay.
So not only metro.
Okay.
Okay, continue.
Okay, then they have compared with percutaneous aspiration with percutaneous catheter drainage, which in studies they have concluded that percutaneous catheter drainage, the pigtail drainage is better. Then outcomes, the presence of malignant disease, factors associated with malignant disease like jaundice, markedly elevated LFT results. Then signs of sepsis appear to be consistent, poor prognosis markers. Then amoebic abscess. So amoebic abscess.
Indications for liver resection in pyogenic liver abscess.
indication pyogenic when it is suspecting malignancy.
MCQ.
Okay.
So infected hepatic malignant neoplasms, hepatolithiasis, or intrahepatic biliary strictures.
Okay.
So if these are all there, we can do hepatectomy. So the indications for hepatectomy in hepatic abscess.
Last time.
Oh, okay. Continue.
Okay. Then amoebic abscess. Amoebic abscess more commonly it is caused by entamoeba histolytica. Then there is another amoeba is there, that is entamoeba disper. This is non-pathogenic form, most commonly seen in male homosexuals, and this is non-pathogenic form. There is no treatment required, and then we should differ from entamoeba histolytica and entamoeba disper to avoid unnecessary treatment. So in contrast to pyogenic hepatic abscess, it is more common in Hispanic man, also younger age, 20 to 40 years of age, with history of travel to the endemic area. So poverty and cramped living condition are associated with high rates of infection. And a male preponderance,
page.
Sir?
I'll change the page, 1457.
Okay.
Okay.
Then a male preponderance of more than 10:1 has been reported in almost all studies. Also, heavy alcohol and impaired host immunity like HIV infection, malnutrition, malignancy, chronic infection, chronic steroid use are risk factor. Then pathogenesis. Entamoeba histolytica is a protozoan and exists in a trophozoite or cyst. All other species in genus Entamoeba are not considered as pathogenic, and not all strains of Entamoeba histolytica also considered virulent. So some strains of entamoeba histolytica is virulent. Then ingestion of entamoeba histolytica cyst through the fecal-oral route is the cause of amoebiasis. It is through the contaminated water, vegetables also a route for human infection. Once ingested, the cysts are not degraded in stomach. Then it passes to the intestine where the trophozoite passed into the colon. So nothing is changed. When it goes to the colon, then only it will release the trophozoites. In colon, trophozoites can invade the mucosa, resulting in the disease. Then here, another one point not given here, that is, it will cause flask-shaped ulcers in colon. Then it is thought that trophozoites reaches the liver through the portal venous system, but there is no evidence of trophozoite passing through the lymphatic. So there is no lymphatic transmission, only portal venous system. As implied its name, entamoeba histolytica trophozoites can lyse the tissues through the complex set of events, including cell adherence, cell activation, subsequent release of enzymes, resulting in necrosis. Important MCQ. Then the principal mechanism of probably enzymatic cellular. This is the principal mechanism for probably enzymatic cellular hydrolysis. Then early development of amoebic liver abscess is associated with accumulation of polymorphonuclear leukocytes, which are then lysed by trophozoites. Then come to the anti-amoebic antibodies. Here, IgA antibodies have been shown to inhibit the cell adherence, which above they have mentioned that it is inhibiting the cell adherence to the chronic epithelium in vitro, so it is good one. So, however, the development of these antibodies does not halt the progression of the disease. Interestingly, in children who lack anti-amoebic IgG have innate resistance to the invasive infection, suggesting an alternative immune-mediated response. Important MCQ. Therefore, is now evidence that cell-mediated helper T-cell response is probably the major mechanism of the resistance. Then pathology. So hepatic amoebic abscess is essentially the result of liquefaction necrosis. Also, the liver producing cavity full of blood and liquefied liver tissue. The appearance of this is anchovy suspicious. Then fluid is odorless unless the secondary bacterial infection has taken place. The progressive hepatic necrosis continues until the Gleason capsule has been reached, because Gleason's capsule is resistant to hydrolysis of the amoeba. Thus, amoebic abscesses tend to abute the liver capsule. Because of that, we may have the pain because of stretching of the capsule. Because of the resistance of the Gleason's capsule, the cavity is typically crisscrossed by the portal triads protected by the peritoneal sheath. So same like pyogenic abscess, next page, same like pyogenic abscess, amoebic abscess also most commonly occur in right liver. In above, they have given the common symptoms. Most common is abdominal pain, 92%. Most common is abdominal pain. There in pyogenic, as it is first, so the most common is fever. Here it is abdominal pain. And both the least common is jaundice. In clinical features, approximately 80% of the patient amoebic abscess present with symptoms lasting for few days to 4 weeks. So the duration of symptom has been found typically less than 10 days. So it will start less than 10 days. The typical clinical picture is a patient of 20 to 40 years of age who has recently traveled from endemic area with fever, chills, anorexia, and right upper quadrant pain, and hepatomegaly. And the abdomen pain is typically constant, dull, and localized to the right upper quadrant. Although some studies have reported that approximately 25% of patients have diarrhea despite obligatory chronic colon infection. Then synchronous hepatic abscess is found in 1/3 of patients with active amoebic colitis. Then jaundice as the result of large abscess compressing the biliary tree. With an average of 22% of the patient, it is occurring. Then tenderness may be in epigastric or left side of the abscess if it is located in the left side. Rupture into the peritoneum with peritonitis occurs infrequently. When it does occur, it is important. It is more often with left-sided abscess. So more commonly, rupture happen in left side of the abscess. So patient present with acutely. Acutely means when the symptoms is less than 10 days versus the present with chronic presentation more than 12 weeks differ clinically. How in acute presentation they are typically
more than 2 weeks.
Hello?
Chronic is more than 2 weeks.
More than 2 weeks. More than 2 weeks. Then acute presentation are typically more dramatic with high fever, chills, and significant abdominal tenderness. In acute presentation, 50% of the patients have multiple lesions, whereas the chronic presentation, more than 80% of the patients have single right-sided, most commonly right-sided lesion. In laboratory, there is no proper laboratory investigation in amoebic liver abscess, like anemia can be there, but anemia is a protective factor for in this one amoebic liver abscess. Then mild abnormalities, LFT, then including albumin, PTNR, ALP, AST, there is slight abnormality of LFT will be there. Then PTNR will be increased. Because more than 70% of the patient with amoebic liver abscess do not have detectable amoebia in their stool. The most useful laboratory evaluation is measurement of circulating anti-amoebic antibodies, which are present in 90 to 95% of the patients.
One mnemonic. So pyogenic liver abscess starts with P. Amoebic liver abscess starts with A. So most common LFT abnormality, it will be different. P for A for P. So amoebic liver abscess, it's A. So most common is PTINR. Pyogenic liver abscess, P. So most common is ALP. P for A for P.
Okay.
Because it will be, we have to remember like this, or else we'll get confused.
Okay.
Pyogenic,
ALP, then amoebic liver abscess,
PTINR, yeah.
Okay. Then come to the next test. Indirect hemagglutinin test was used extensively in past and high sensitivity rate of 90%. But this test has largely replaced by enzyme immunoassays, which detect presence of antibodies against the parasite, are simple and rapidly performed and inexpensive. So we are nowadays most commonly we are using an enzyme immunoassay, and it has reported sensitivity of 99% and specificity greater and higher than 90%. Then come to the antigen detection. Antigen detection kits have been evaluated in endemic areas. These kits can detect Entamoeba histolytica lectin antigen. Entamoeba histolytica lectin antigen in the serum and the liver abscess pus. So in both serum and liver abscess pus, we can detect this lectin antigen. And however, the sensitivity may decrease if the test performed after the treatment of metronidazole. So it's better to do before the treatment. And radiological treatment, radiological studies. Here, blind chest radiographs are abnormal in approximately 15% of the cases. Then elevated diaphragm, pleural effusion, atelectasis of the lung can be there. Then abdominal ultrasound has reportedly accuracy of approximately 90% when it is combined with typical history and clinical presentation. Then typical finding is rounded lesion abutting the liver capsule. Trying to stretch the liver capsule can be there. Also, it is then in CT scan, it is hypoechoic and non-homogeneous. In CT is the investigation of choice. And it is differentiating by CT. We can differentiate amoebic from pyogenic abscess and the rim enhancement noted in the pyogenic abscess. In that actually in amoebic abscess there will be surrounding the abscess there can be a mild edema can be there, and MRI also can be used for this one, but MRI is usually used for tumors of the liver. The nuclear medicine studies such as gallium scanning or technetium 99 liver scans can be helpful in differentiating pyogenic from amoebic liver abscess. Then when this workup is still not definitive and diagnosed,
page change.
When this workup is still not definitive and diagnostic uncertainty present, two options should be considered. First one is, first we have to give therapeutic trial of anti-amoebic drugs can be used first, then we will see whether it is working or not. If it is working, then we will continue. If it is not working, then we will go for second option, that is diagnostic aspiration. Then should be the pyogenic abscess would be bacteria and leukocytes, whereas in amoebic abscess it will be as Anchovy-Sars pus. In patients for whom neoplasm or hydatid disease is in differential diagnosis, aspiration should not be attempted. Then treatment, most commonly by metronidazole, has to be given. The dose is very important, that is 750 milligram orally 3 times daily for 10 days, which is curative of more than 90% of the patients. Other nitroimidazoles are secnidazole and tinidazole can be given. Clinical improvement is seen within 3 days. If response to the metronidazole is poor or the other drug is not tolerated, then other agents can be used. The other agent is emitin hydrochloride. This is an intramuscular injection. Emitin hydrochloride intramuscular injection. A more attractive other option is chloroquine. Also, some luminal agents are also there. These are idoquinol, paramomycin, then diloxanate furoate. Usually, generally, aspiration is recommended for diagnostic uncertainty with failure to respond metronidazole therapy in 3 to 5 days, or in abscess through thought to be higher risk of rupture, and usually in the left side. Abscess larger than 5 centimeter and left side of the liver thought to be carry the high risk of rupture, and aspiration should be considered. Outcomes. In outcomes, the overall incidence of rupture ranges from 3% to 17%, 1 MCQ. Then laparotomy is advocated in past for this complication, but nowadays we can treat this successfully by percutaneous drainage, pectoral incision. Then rupture, it can usually it can rupture into peritoneum or pericardium or pleural fluid. If it is rupture into the bronchial, then we will give it the patient in prone position. By cough, we can taken out the spurs. When abscess ruptures, mortality ranges from 6%. Ranges from 6% to 15%. So factors independently associated with poor outcome are elevated serum bilirubin level, encephalopathy, hypoalbuminemia, multiple abscess cavities, abscess volume larger than 500 ml, anemia, and diabetes.
Okay, one more. The previous paragraph, last 4 lines. Left-sided abscess can rupture into the pericardium and can be manifested as asymptomatic pericardial effusion or even tamponade. It can be treated by aspiration or through pericardial window.
Okay.
Okay.
Then the average time to radiologic resolution is 3 to 9 months. So though the patient is asymptomatic, but still the patient will have the cavity for 3 to 9 months. Then come to hydatid cyst. Hydatid cyst is a echinococcosis or zoonosis that is primarily a sheep grazing area, most commonly sheep grazing areas of the worldwide, but this is more common worldwide because dog is the definitive host. It is most common in endemic areas like Mediterranean countries, Middle East, and Far East, and South American, Australia, New Zealand, East Africa. And there is no human to human transmission. There are 3 species they are given here. That is Echinococcus granulosus, which we know. Then multilocularis, which is malignant one. Then another one is Echinococcus legatus. This accounts for small number of cases. Dogs are the definitive host in Echinococcus granulosus. In the adult tapeworm in dog is attached to the villi of ileum. Then up to thousands of OR pass daily and deposited in dog species. Sheep is usually as considered as intermediate host. Human is an accidental intermediate host. In human, in the duodenum, is the parasite embryo releases ancosphere. So it is not colon or other, it is duodenum. In parasitic embryo releases ancosphere containing hooklets that penetrate the mucosa, allowing access to the bloodstream. In the blood, the ancosphere reaches the liver and the lungs, then where the parasite develops into larval stage, the hydatid cyst. 3 weeks after the infection, the visible hydatid cyst develops, which then slowly grows in spherical manner. Then come to the layers of hydatid cyst. The first one is pericyst, fibrous capsule direct from host tissues. Then cyst wall contains 2 layers. So next layer is also called as outer gelatinous membrane or ectocyst. Or hyaline membrane. Then the inner germinal layer, endocyst. So brood capsules are small intracystic cellular masses in which future worm heads develop into scoliosis. In a definitive horse, the scoliosis develop into an adult worm. But in humans whom are intermediate horse, they can differentiate only into a new hydatid cyst. Freed brood capsules and scoliosis are found in hydatid fluid and form so called as hydatid sand. See the diagram 54.31. The first one, A, is hydatid sand. We can see the sand-like substance deposited. Then second one is B, is a rosette-like appearance, honeycomb-like appearance. Then third, what they are telling is it is looking like an amorphous mass or solid mass like that. In fourth image, they are telling the surrounding layer is thickened and it's looking like calcified. This is calcification of the surrounding layer. Then calcification of the hydatid cyst, however, does not always imply the cyst is dead. In Bailey, they have given on classification, WHO classification, group 1, group 2, and group 3. In group 1 is called as active group, which cysts are larger than 2 cm and often fertile. In group 2, that is transition group, the cysts are starting to degenerate alive to death. So entering into the transitional stage because of host resistance or treatment. So that is called transition group. Then group 3 is inactive group, that is degenerated or degenerated partially or totally, like partial calcification or total calcification. Then come to the next column. Hydatid cysts are diagnosed in equal numbers of men and women. So it is equal in both men and women at around 45 years. Approximately 75% of hydatid cysts are located in the right river and usually it is solitary. The clinical presentation largely asymptomatic. The most common presenting symptom is abdominal pain, like this one, amoebic liver abscess. Then it can be also dyspepsia, vomiting also can be there. The most frequent sign is hepatomegaly. Jaundice, fever are each present approximately in 8% of the patient. Free rupture can result in dissemination of echinococcosis and potentially fatal anaphylactic reaction. Then radiological investigation. Ultrasound is the most commonly used and worldwide. In simple, hydatid cyst is well circumscribed and budding signs on cyst membrane and may contain free-floating hyperechogenic hydatid sand. A rosette-like or honeycomb-like appearance is seen in when daughter cysts are present. The cyst can be filled with an amorphous mass, which can be diagnostically misleading. Then comes to the next page. The most commonly the treatment is surgical treatment, but in older patient with small asymptomatic densely calcified cysts, conservative management is appropriate. Then preoperative steroids can be recommended, but not or universally used. Then come to the below. The cyst is unroofed, which can be then followed by number of possibilities including excision, pericystectomy, or marsupialization procedures, or leaving the cyst open, or drainage of the cyst, or omentoplasty, partial hepatectomy, or encompass the cyst. These can be done. The next column, when the bile duct communication is diagnosed preoperatively or at the operation theater, it must be meticulously sought after. Like I say, we can suture it with Wickel 30 or 20. Or simple suture repair is often sufficient, but major biliary repairs approach through the common bile duct or post-operative ERCP may be necessary. And another one important MCQ is PAIR. Most common scolicidal agents are also hypertonic saline 15 to 20%, or ethanol 75 to 95%, or 1% povidone iodine. These are given in Bailey, are used as a scolicidal agents. And another one important thing is we have to do the surgery in antibiotic This one anti-helminthic cover, that is albendazole or mebendazole, which is useful. Then preoperative treatment may decrease the risk of spillage and is reasonably safe in practice. Then recurrent pyogenic cholangitis. Most commonly here, recurrent pyogenic cholangitis implies the oriental cholangiohepatitis or hepatolithiasis, but also because of repeated attacks, this cholangitis secondary, it can be also due to biliary stones or strictures. This is most commonly in men or women equally affected. It is common in 20 to 40 years of age. It is common in lower socioeconomic state classes also. Then this one, this causes stones or strictures. These stones are bilirubinate stones, that is calcium bilirubinate, stearate palmitate, that is brown stone, pigment stone, which is more common in infection. The infection agents are clonalkis sinensis, Ascaric lumbricoids. Infection has been noted. Then strictures can be found anywhere in the biliary tree, but usually involved in the intrahepatic main hepatic ducts, most commonly in the left hepatic duct. So in recurrent pyogenic cholangitis, most common affected is left hepatic duct stricture. So gallbladder is also involved in approximately 20% of the cases. Cirrhosis and liver failure are seen only in long-standing cases. Usually multiple after operation, there will be cirrhosis and liver failure can happen. Then duodenal fistulas and acute pancreatitis also can happen. Then this is a pre-malignant condition. Cholangiocarcinoma can arise. In it can cause obstructive jaundice also, but the obstructive jaundice is like not complete jaundice, like not complete obstruction. So marked jaundice and pruritus are not common. There is usually leukocytosis and abnormal LFT results in consistent with biliary obstruction. Direct cholangiography is performed endoscopically or transhepatically and is considered important study complementing the cross-sectional imaging. But nowadays MRCP or combined with cross-sectional imaging and cholangiography is one non-invasive test which may ultimately replace the direct cholangiography. Then, although non-operative approaches such as percutaneous transhepatic cholangioscopic lithotomy have been developed, surgical treatment remains the treatment of choice. Because in case of poor surgical risk patient, we can go for like a conservative management. The goal of operative approaches is to clear the biliary tree of stone or stricture, like enlarging the strictures or resection of the strictures. It should be there. Many cases require only exploration of common bile duct with or without hepaticojejunostomy. In complicated cases, providing a permanent access to the biliary tree for an interventional radiologic procedures by extending the Roux-en-Y hepaticojejunostomy to skin or subcutaneous tissue space, which has been successful approach. Like we usually close the stump, but instead of closing, we just put it as a stoma, so that in future from the stoma we can go inside and clear the infection. Then other potential necessary procedures include stricturoplasty and partial hepatectomy. And partial hepatectomy is advocated for patients with intrahepatic strictures, hepatic atrophy, liver abscess, or suspicion of cholangiocarcinoma. That's it, sir.
இதுல மட்டும் உண்டு இந்த ஹைடாக்கட்ல the investigation which will give us which will show cystobiliary communication, which is the investigation done.
Cystobiliary communication, MRCP, sir.
Actually, அதோட in patients அந்த below image 54.32 அந்த small paragraph.
Okay.
1461. In patients with suspected biliary involvement, ERCP or percutaneous transhepatic cholangiography may be done.
Okay. So PTBD will be better.
PTC. Percutaneous transhepatic or ERCP.
Okay.
So, okay, record stop.